All right, everyone, good morning and welcome to Neurology Grand Rounds. Okay, so it's not working. The floating controls keep popping up no matter what. So this is today's CME code, which is conveniently displayed for the folks at Grand Rounds. Welcome to the new, I mean, they're not here, but welcome theoretically to the incoming Duke Neurology class of 2027. And a sincere round of thanks to everyone who did interviews, talked to them, Zoomed with them, because it's a great group. So thank you all very much. A little interesting, 66 years ago, Will found that in 1957, Duke received the first non-intramural grant to establish a regional center for the research on aging, with the chair of psychiatry serving as the principal investigator. And at the same time, Duke was building a new $4 million addition to Duke Hospital. That's probably in the time when they built Schaefer Stadium for like a cool $6 million back in the 70s. There's only like one person in this room who knows what I just said. I just wanted to share this. This was in the Herald Sun. There's a website called TripAdvisor that, you know, tells you where to go travel, which if you have a mind to travel. And the #1 tourist site in the United States in terms of, you know, 5-star ratings by people who go there is the Great Smoky Mountains in our own state of North Carolina. How many people in this room have been to the Great Smoky Mountains? Is it nice? Oh, all thumbs up. Yeah, haven't been there. So it's just west of Asheville, apparently. It's a 5-hour drive. Our neurology all-star for the first time is an internal medicine resident. Yeah, Raul, congratulations. Nominated by Jordan and Christine, admitted several patients. Carmen, when we were on, we'd admit 13, right? So you get a coffee cup for several now. And anyway, thank you for your work. And the cup, hopefully we'll be able to find you with your coffee cup. And if you can't, Joel has a bunch, so he could lend you one. And Joanne Lee was nominated by Dylan Ryan. Okay, 191. Okay, Joanne Lee nominated by Dylan Ryan, or Ryan Dylan, for pitching in at the VA after clinic was canceled. She came in and did an inpatient EMG to diagnose somebody with motor neuron disease. That's both nice and sad, but congratulations. Your coffee cup is coming. Oh, and Joel Morganlander is in the news talking about his APP residency, and now there's an actual consortium of neurology APP directors. A research roundup, Vern Jewell looked at the serology of checkpoint inhibitor myasthenia gravis, and Atif wrote a paper on shedding light on symptom severity and non-prescription therapies in debilitating idiopathic hypersomnia. Again, your assignments, the DHIP agreements, the department's probably at 90% right now. They must all be signed by March 28th if you're a PDC and March 31st if you're a CPDC. If you don't know what I'm talking about, contact Megan Phillips. The faculty reviews were supposed to be in, and I believe Doximity voting for US News Best Hospitals is still opening. Again, this is today's CME code. And our case presentation is Gabriella Torrealba-Acosta. How did I do? Oh, not bad. Not good, but not bad. All right, here you go.
How do I get
Just hit ESC, yep. Make me go away.
Here. Okay, all right. Good morning, everyone. So the case I'm presenting today, I named it a case of reversible and recurrent herniation. So this was a 36-year-old female that was recently diagnosed with an intracranial mass, initially manifested by seizures and panhypopituitarism, and she was started on Keppra and Vimpat, and then hydrocortisone and levothyroxine. And she was admitted to our neuro ICU as a regular post-op monitoring for an elective tumor resection. This is a tumor. You see it's arising from the supracellular region. It's mainly dependent of the septum pellucidum and the lateral ventricle. Okay, good. And this is her post-surgical MRI with the expected post-surgical changes, a little bit of pneumocephalus and some subdural collections already building up, mainly on the left side. So she was admitted the day before Christmas and pretty much like 1 month of admission. And during her admission, she had 3 episodes of herniation. So the first one, right after surgery, she developed diabetes insipidus. And as we were trying to figure out what was her best dose of desmopressin and fluids, you see how her sodiums are just shifting widely, to the point that when we get to the 1st of January, her sodium goes from like 150 to 135 very quickly. And this possibly causes her brain to swell up and also dehydrate. And this worsens her bilateral hygromas and also causes a right sigmoid dural sinus thrombosis with a little bit of jugular thrombosis. So all of that caused her to herniate. We intubated her, give her hypertonic, mannitol. She gets an EVD for ICP monitoring, and she started on heparin grip. And then she's doing great, to the point that the next day she's extubated, but a few days afterwards, she herniates again. This time, her sodium was more stable, so you can see, as well as the desmopressin dose, but we had one added information. We had now ICPs. When ICPs, right after we placed the EVD, they had been averaging from 7 to 10, but for some reason, on the 5th, the ICP shoots up to 30. So the EVD is open, she drains 20 cc's of CSF, and then she herniates again. What happened this time? She had been developing, or her bilateral hygromas grew, and she's developing this pseudomeningocele that interestingly is working as a one-way valve, where CSF is coming out of the ventricles into the pseudomeningocele. It's building up pressure that it's also pushing down on the brain and causing this herniation. So what happened this time? Neurosurgery, very cleverly, they pulled back the EVD a few centimeters, so it would start draining the right subdural collection and no longer draining the CSF. And as you can see, this is her next day CT head. The hygromas are smaller and the pseudomeningocele is pretty much resolved. So she's getting better to the point that a few days afterwards, her EVD is removed. She's extubated on the 12th, and then she's starting to get ready to be transferred out. And the first day that she works with physical therapy, she stands up and then she herniates again. She has like this brief 15-second period of unresponsiveness and extensor posturing. What happened this time? She no longer had the EVD. Her left hygroma grew up and she developed acutely a 6-millimeter midline shift. So what happened this time? Neurosurgery placed a subdural peritoneal shunt. And then finally, she's able to be discharged on apixaban and desmopressin. And this is her CT head a few months afterwards. You can see how her shunt drained very well both hygromas, and she no longer has the pseudomeningocele. So this is an interesting case of recurrent and repeated herniation. Thank you.
Thank you. It's a lot like Friday in dementia clinic. All right, where am I at? I guess all right, I won't blow this up, but today we have a tag team doing grand rounds, both from the neuro ICU. So the first is, or possibly the second, Cina Sasannejad, who is an assistant professor of neurology by way of Stony Brook, UCLA, and then Yale, and Carmen Graffagnino by way of Canada. So Carmen is a professor of neurology. He went to the University of Western Ontario for his MD degree and then did his residency there, as well as his fellowship. And you came here for ICU?
ICU and more stroke.
And more stroke training, yes. So, and you've been here a lot, and you have a house not in the Smoky Mountains, but close, right?
The Appalachians.
Yeah.
outside of Boone.
Outside of Boone. And Carmen and Cina are going to talk to us today about traumatic brain injury from acute management to long-term care. So Carmen, you're first. Okay.
Thank you, Rich.
I'll just make a comment that the hybrid grand rounds have really worked out well. They've worked out to the point we're out of coffee, both coffee cups and coffee. So that's a pretty good sign. Will's going to get us 2 buckets of coffee starting next week. So thank you all for coming.
Well, thank you, folks. So I'm going to talk a little bit about traumatic brain injury, beginning with the acute management and following it all the way through. But I always find it's more useful when you have a real human being to talk about. So this was a gentleman I looked after about 6-7 years ago. He was an 18-year-old who thought there was no such thing as speed limits on motorcycles and decided to hit a truck going about 95 to 100 miles an hour. It was a T-bone kind of crash right into the side of a transport truck. He got brought in level 1 trauma, had a GCS of 4 on presentation, multiple fractures, his tibia, multiple ribs, contused lungs, and he was admitted to the ICU. So traumatic brain injury management actually begins in the field with the EMTs and paramedics that pick these folks up. But I'm going to focus on a little bit about our ED management. This is really the only place, I'm probably going to get shot for this, the only place where the Glasgow Coma Score has value. Even though we use it as a surrogate for a neuro exam in the ICUs, it was developed to try and understand how somebody was going to do after a brain injury. The usefulness of the GCS is that when you're comatose, which means a GCS of less than 8, you have to try and figure out, is this because your brainstem's been schmucked and your ARAS is gone? Or is it because you have bihemispheric injury? And again, I'm going to be radical and say that really the only cranial nerves that matter in acute trauma are 3, 5, 7, and 8. Because the ARAS that keeps you awake, if you're trying to understand coma, begins at the mid-pons. And so anything below that does not explain why your patient is not awake. And CT imaging is really critical in trying to understand. So what is it we see on CTs? And we have a number of different findings. On your left, you see a subdural. In chronic old folks, subdurals are usually due to venous tears as the brain shrinks down. But in acute trauma, many subdurals are actually arterial. On the right, you'll see an epidural bleed, and you can tell it's an epidural because it has a lens shape and it follows where the sutures are. So the blood can't go past those sutures. Most of the time, this is associated with the middle meningeal artery tear. On the left, you'll see a subarachnoid hemorrhage. And this is a traumatic subarachnoid, which is quite different than what you see here where the cisterns are full of blood on the right. On the right, it's the pattern we see in aneurysmal. When we see this in a traumatic injury patient, we have to question whether the trauma was due to a subarachnoid that led to them having their motor vehicle accident or falling. And then you have contusions, and contusions tend to be bifrontal or anterior temporal because that's where your brain schmucks against your frontal cortex or the sphenoid wing of the middle fossa. These contusions will bloom over time. So most often, if we see a normal CT acutely, we'll repeat one 6 hours later to see if there's been an evolution. And then lastly, we'll see tiny little dots. These are called microhemorrhages. They tend to be in the white matter. And this is what happens to your brain when it gets sheared. So this is usually a torsional injury or a sudden deceleration, acceleration. This is diffuse axonal injury. And these are patients that really fool you because the CT can look remarkably unremarkable, and then your patient dies 6 hours later. Now, skull fractures are very common in acute trauma as well. And the pertinent issue about skull fractures is the associated injuries. So temporal bone fractures always make you worry about epidural bleeds as you damage the middle meningeal artery. And for the fellows, residents in training, the 2 classic findings that we see clinically, when you have orbital frontal fractures, you'll see these raccoon eyes. And when you have posterior occipital fractures, you're going to see battle sign, which is blood behind the ear. vascular imaging is now part of acute traumatic brain injury, particularly if you have a fracture through the petrous bone, because this is where your carotid artery can dissect. And you'll end up either with a dissection and an ischemic infarct downstream, or the formation of pseudoaneurysms or even subarachnoid hemorrhages. And this really makes life complicated for us, because now you have somebody with multiple traumas and bleeding and a dissection. But very critical to make sure we don't miss CT imaging on all these acute severe TBIs. What did our patient have? This was his CT scan. He has bifrontal contusions. Again, severe deceleration injury with his head into the side of a truck. So what are the primary principles? Again, begins in the ED, where you're doing your primary survey to try and understand. The GCS is your first neuro exam. Then you go back and do a much more detailed one. And the goals in the intensive care unit, since we can't stop the injury that already happened, is to minimize secondary injury. And secondary injury is mostly related to the inflammatory response to the trauma, and then secondary ischemia from impairment of blood flow. So what we're trying to do is save the brain that isn't dead, brain that still has potential, and allow the brain that's sublethally injured to recover. So how do we maximize blood flow to the brain? Because it's pretty tricky to measure actual blood flow. And just for a reminder, for those interested in vascular flow, normal is 50 to 80 mLs per 100 grams per minute, with 30 to 50 being acceptable. When you're starting to get into 15 to 20 mLs per 100 grams per minute, you're getting into oligemia. And what we have to assume in anybody with a brain injury is that they've lost autoregulation, and the blood flow is linear and proportionate. So blood delivery is proportionate to blood flow, and you've lost the ability to vasodilate and constrict, which is not altogether factual. But so how do we measure blood flow? Since we can't directly, we can directly measure, but it's quite difficult to do. And so what we do is we estimate blood flow based on perfusion. And so this thing that when I first started neurology, I thought was a political group, the Monroe-Kelly doctrine. But these two physicians said, basically our head is a box, and the box doesn't expand. And so you have brain and you have blood and you have spinal fluid. And when you add one, if you don't get rid of something else, then the pressure starts to go up, and pressure will only discharge through areas where there's availability to move, which is your foramen magnum, thus herniation. So how do we estimate blood flow? And it turns out that there's been quite a few, both animal and human studies, looking at if I have a certain amount of perfusion pressure, what does that correlate to blood flow? And we know that cerebral perfusion pressures above 50 correlate with cerebral blood flows of 20 to 30 mLs per 100. So we didn't just make up a number, we kind of made up a number and said, let's at least guess. And we target 60 because patients are not static, and there are days when your blood pressure dips, your ICP goes up. So that gives you a little insurance policy. When I first started, it used to be 70. And we realized that if you overperfuse in a brain that's lost autoregulation, you actually develop cerebral edema. So it can be harmful to give too much blood. So how do we know what the pressure inside the brain is? And we have a number of toys we can use, but really the most common and standard of care is where you put a catheter into the ventricle, as Gabriel was showing us earlier, and you measure the pressure inside the ventricle. And we can spend an hour talking about the limitations of intraventricular pressure monitoring and all the assumptions that you have to understand to interpret these numbers correctly. But it's still the go-to because it does two things for us. It gives us pressure measurements, and we can take CSF out and help that Monroe-Kelly doctrine concept where we take something out of the brain to allow the swollen brain to fit in there. We can also measure pressure directly inside the parenchyma of the brain with a fiber optic pressure transducer. And now we got really fancy ones that can tell us how much oxygen saturation is in the tissue, the temperature of the brain, and we can even do metabolic measurements. We don't do that here, but if you measure with microdialysis, you can look at lactate, pyruvate, and yes, Krebs cycle was something we use. And looking at the ratio of pyruvate to lactate as an estimate of anaerobic versus aerobic metabolism, so we can optimize. And the game here is optimize oxygen delivery to brain that is at risk. When you put a ventricular catheter in, you're going to get a nice little pretty picture here on the left. And the P1 wave is when your ventricle contracts and a swoosh of blood goes inside your brain. And it causes a rise in the blood, in the pressure in the brain. Now, as that blood distributes through the brain, you're going to get another little wave of pressure elevation as the brain fills up with the blood that last systolic ejection did, and you get P2. But if your brain's compliance is low because it's stiff, then as the blood distributes through the brain, the pressure is going to continue to rise. And so when we see the P2 going up before the P higher than the P1, even if the brain pressure is normal, alarms start to go off because it's like this brain is getting stiffer and stiffer, which means less blood is flowing in. And then P3 is as the blood drains out of the brain and the right atrium fills, there's a little backwash. And sometimes we'll see a P4 with an atrial contraction, but this is quite useful doing this waveform analysis to understand, not just waiting for those quote 22 number to pop up, but to say, how is this person's brain behaving? So the initial care of our patient was neurosurgical colleagues put in an EVD. His ICP was 26 at the time of ICU admission. So what do we do now? Because based on our numbers, it looks like this gentleman's brain is not going to get the blood flow it needed, particularly in the bifrontal border zone between the dead brain and the brain at risk. So these are the bread and butter things that sound really boring, but for y'all, when you're doing rounds and you're on the floors, in particular, I think this is most useful. Not just the nurses in intensive care, but let's say you go do a consult on maybe the CT ICU where lots of our business comes from, and somebody suddenly blows a pupil. Before we go worrying about doing a decompressive craniectomy or sucking clot out or giving mannitol, there's really bread and butter things. First, raise the head up at least 30 degrees to facilitate venous outflow. Keep the head neutral. And I like doing this when I'm in the ICU when somebody has an EVD. If you turn somebody's head to the side or just gently compress one of the jugulars, you can get a 10 to 15 millimeter increase in ICP just by turning the head to the sides. So if your patient's on the bed flat like this, you're really working hard to try and raise that ICP for this person. So very simple things: head up, head in the middle, make sure they're breathing, that they're ventilating correctly. Now, in our ICU, like in the intensive care setting, pain is an extremely important thing to treat. And you cannot sedate pain away until you put somebody under anesthesia. And there's an enormous reluctancy to use appropriate amounts of pain management. And if you manage somebody's pain, you may not need as much sedation. So we want to be very generous with the opiates at first. And there's always this concern, well, what about my neuro exam? But once you have your baseline, you can follow that closely with your patients. And by the time we put an ICP monitor in, what we're saying is my exam is no longer as useful as understanding physiology. So again, pain management, very important. Sedation, and don't just say sedate to comfort, because nobody knows what that means. So we have an objective tool, and we use the Richmond Agitation Sedation Scale here at Duke. We can use fancy EEG, and again, that's another interesting discussion about using either processed EEG called BIS or a full channel EEG, but no one seems to be able to read those outside of the electrophysiologist. So those are not very useful for bedside management. So processed EEG data is much more useful. We want to be very aggressive with bowels. And when you come in the ICU, it's like, what's your obsession with going to the bathroom? I mean, this is like a 10-minute discussion almost every day. It's because if your abdomen swells, your inferior vena cava gets compressed, and then you can't get blood flow returning back to the thoracic abdominal cavity, which means your intracranial pressure is going to go up because your blood can't drain out of your brain. And in really aggressive trauma centers, They will actually even do a laparotomy, open up the belly, put a zipper and a patch to decompress the belly in patients with multiple abdominal trauma to try and reduce brain pressures. We want to avoid hypercarbia, so we're monitoring that very closely, and avoid hypovolemia, because again, if you're trying to deliver optimal blood flow to the brain, going back to physiology, there's this thing called a Starling curve, and your heart can't pump out what it doesn't get. So again, be very aware of the importance of volume. Now, when do we treat ICPs? And we realize that when the intracranial pressure goes above 22, those in and of itself, those episodes are associated with worse outcomes. And so we do a fine dance between an intracranial pressure reduction and cerebral perfusion pressure. And trying to, if your cerebral perfusion pressure is low because you're hypotensive, you're in shock, treat the shock and not just give mannitol. Whereas if you have a good cardiac output and that's working well and your brain is swelling, then we have to treat the reason the brain is, the ICP is high. So what can we use? And again, mannitol has been the go-to, usually 0.5 to 1 gram per kilo when an ICP crisis hits. And there's different philosophies, but if you look at the literature, and that does not mean that's always what we do here, and it's variable, so I want to put that caveat, but treating empirically over and over does not help your patient, because what we're looking for is osmolar shifts, osmolar gaps. So if the brain's osmolarity is lower than the blood's osmolarity, then fluid will flow towards what's hyperosmolar. But after a day or two of hyperosmolar therapy, your brain gets smart and says, this isn't normal, and equilibrates. So now it takes a bigger osmolarity to suck water out of the brain. Plus, we only pull water from brain where the blood-brain barrier is intact. So you're actually not reducing edema in the injured brain. You're shrinking the rest of the brain down to allow more room. So you can actually even theoretically worsen midline shifts if you do it too quickly. When we do this is to rescue a patient who's acutely herniating and decompress it by allowing a little bit more room. But you don't want to perpetuate this day after day after day, unless your ICPs are refractory and stay high. Once you start getting to those upper levels of osmolarity, we get into a complication where now the mannitol itself contributes to the measurement. And so we do a calculation and a measured osmolarity, and we look for the gap, which tells us how much of what I'm seeing is due to just that drug in the body, and am I able to still give more and get a benefit? Now, what if you're on the wards and somebody acutely blows a pupil, you're on the stroke service, somebody develops edema that was unpredicted, they were like 6 days out from their MCA stroke, or they had a hemorrhage, which by the way, peaks at about 8 to 10 days for the edema. So we get surprised a lot in these late hemorrhages. And there's no mannitol, the nurses don't know how to give it. Furosemide is actually a really good acute bail you out while you go getting pictures. And you don't send the patient down for a CT scan. That is never the answer acutely. You got to stabilize that person. If you're going to send somebody down without an airway protection, without initially treating, you're going to get a really pretty picture and then have a fixed blown pupil in a dead patient. So treat first, pictures later. And in this case, 40 of Lasix may give you a little bit of a breather while you secure airway, hyperventilate the patient, and then get them down for a picture. Now, what if you've done mannitol and it's already maxed out, or if you're already a little hypovolemic? We use hypertonic saline. I'm going to go out on a limb and say that it is voodoo medicine to empirically put people on hypertonic saline to raise their sodiums above a certain level. So what you want is normal sodium. So, above 140 would be more than acceptable. You don't want hyponatremia, because that does facilitate fluid fluxes. So I'm not saying don't treat hyponatremia, just don't empirically put people on hypertonic saline expecting you're going to prevent edema from happening, because that doesn't work. And so we use 23% because it's super concentrated, and 30 cc's at 23% is extremely effective. Now people become enamored with 23% and say, oh, it's better than mannitol. And truly, it is not better than mannitol if you use isoosmolar doses. And so people used to compare 25 grams of mannitol, which is what we use for most patients, to 30 cc's of hypertonic saline and realize, wow, hypertonic saline looks better. But that's because it's the osmolarity of 37.5 grams of mannitol. So again, you have to be selective. Are we treating volume? Are we treating pressure? And really prolonged use of hypertonic saline makes you acidotic because of all the chlorides. So we do a couple little tricks to try and neutralize that, but I don't want to get into that. So can we do better? Can we do better than guessing cerebral blood flow based on the perfusion pressure and assuming that there's no autoregulation? And so what's come along the way now is looking at the actual saturation of oxygen in the tissues themselves. And this is called PbTO2, partial pressure brain tissue oxygen measurement. We use a catheter called the Lycox. So people now call it a Lycox monitoring, just like we say use Xerox photocopies. That's a trade name. What we're doing is tissue oxygen measurement. And by the universe's incredible coincidence, the Lycox, the PbTO2 numbers that we get correlate exactly with cerebral blood flow numbers. So when your PbTO2s are less than 20, it turns out that it works to be basically less than 20 mLs per 100 grams per minute. That was a pure coincidence that the two units worked out because they're not the same measurements. And does this work any better than just using pressure? And we were involved in the big clinical trial called BOOST several years back, at least BOOST 2, which was the dose and safety finding study of this, and found that it's a very safe way of monitoring patients. And patients where you have data on both the general perfusion from the ICP and the tissue numbers actually had a strong trend towards lower mortality and more functional independence. So now we're in the phase 3 definitive trial to see if this becomes a standard of care. And this is kind of what you get. You have one of these little bolts, and you are getting this waveform on the left there, up here, where we're looking at and then this is my favorite kind of intensive care because I love driving standard cars. And here you're managing the oxygen, the blood pressure, the intracranial pressure, the tissue perfusion, the hemoglobin, and you're not just making up a number, but you're saying where is the numbers that are contributing to this hypoxemia and manage the problem rather than the number. So it's clinically a very interesting way, and we're very excited about the phase 3. So this is what we call multimodal monitoring. So you're measuring pressures, you're measuring tissue, your microdialysis is the centers that are looking at physiology. And then the most useful but least standardized way of managing is looking at the electrophysiology of the brain, because your EEG is an extremely sensitive marker of brain unhappiness, but it's not specific and it's very difficult to interpret. And we have yet to come up with an algorithm of quantitative EEG that can tell us this part of the brain has become unhappy because it cannot generate a potential. And now I'm getting either loss of amplitude, loss of entropy, alpha delta ratios. And this is, again, for my colleagues who do electrophysiology, this remains a big challenge. When you get to tier 3, we're now into extremely difficult to manage patients. The brains have become severely swollen. You've maximized osmolarity, you've maximized sedation, you've maximized analgesia. You've got them in the pressure range as good as it can be. And so now we go into near anesthesia. We go into much, much deeper sedation. I like using propofol because propofol both is a sedative, but it also decreases cerebral metabolic function. So it actually reduces brain oxygen requirements. And paralysis will take away a lot of the tone of the belly and the work of breathing, which can also reduce ICP. As a last resort, we use barbiturate coma, but every single study of barbiturate coma has shown no difference in clinical outcomes or independent function, even though your numbers look really good. And it may be that that's just a sign that you're at end stage brain damage. Temperature also helps for ICP control, even though studies of randomizing people to cooling versus non-cooling for functional outcome in TBIs have been negative. In my opinion, there were a lot of faults in those studies. A lot of them, the temperatures were not instituted until they were either herniating or they were instituting in people that didn't need it. So again, I think the jury is not completely out on the use of temperature. My other pet peeve in life here in intensive care is that if you prognosticate wrong, then your prognosis becomes correct. So if you tell somebody they're going to die and you take them off the ventilator at day 3, they die. And we are learning more and more how unbelievably poor we are at prognosticating. And this study I thought was very elegant. I'm not sure whether Dr. Sasannejad is going to mention it too, but if it does, good, it'll be repetition. This was a paper published in JAMA Neurology just a couple of years ago, and they had a huge cohort of patients with an entire range of traumatic brain injury from 3 to 15 GCS scores. But they divided this analysis into those that had severe TBI based on a GCS of 3 to 8 versus moderate 9 to 12. And at 2 weeks post-injury, only 12% of the patients in the severe group had reached what they call a favorable outcome. This is a Glasgow outcome score, which is like a backwards modified Rankin. So here, the higher the numbers, the better you do. And 4 to 8 means that you are not institutionalized. You're able to live with family, not necessarily fully meeting your own activities, but you're not, you know, so if you came in with a GCS of 4 and you're back with your family, even if they have to help you bathe, most people think that's pretty good. And then good outcome, 7 and 8 means you're independent. That's like a Rankin 0 to 1. But if you look at patients with TBI and 2 weeks later, they're up to 12%. And by 3 months, your ability to be independent is up to 45% in people that were in deep coma. It's almost half of the patients by 12 months are independent, like not independent, but living, you know, non-institutionalized. And if you look at those that recover fully, at 3 months, it's 8%. It goes up to almost 20%. And by 6 months, 1 in 5 patients are completely independent that were deeply comatose. And almost 13% have 0 deficits. Oops. So in the moderate TBI group, the data is even better. And these patients, you know, by 2 weeks, almost half were improved. And by a year, like 6 months, 75% by 12 months had independent living, and a third were completely independent, with 20% of these patients being normal, having no deficits at all. Our patient that I presented, you know, my point is if you prognosticate early and you do it wrong, everybody dies. So what happened to our guy? He actually went from tier 1 to tier 3 in the first 7 days. So he was into deep anesthesia, paralysis, hypothermia, mild, like to 36, just to control ICP. We did have a Lycox in him, never allowed his numbers to get less than 15. And after 21 days in intensive care, he woke up and made it to the floor. He actually went and he now runs his father's car business. They had a car dealership. He's become a bodybuilder. He's married. He has 3 children. And every year on the anniversary of his injury, he sends me an email thanking us. So with that, I'd like to pass it on to my colleague to talk about what happens once they leave the hospital.
Okay, thanks everybody. Thank you, Carmen. Thank you, Gabriel, for an excellent case presentation. Thank you, Rich. And thanks everybody for being here. And to all the Zoom people, thank you as well. So I am going to discuss what happens after. So long-term treatment of TBI. I do not have any conflicts of interest. So I'll begin with secondary damage. Secondary damage, I think, is a good link between the first and second talks. And so various mechanisms start to take effect in the initial days and weeks after a TBI. Inflammation, receptor-mediated damage, oxidative damage, calcium-mediated damage, these are all important mechanisms that interrelate and differ in some part depending on which particular mechanisms of TBI have occurred. And so if we compare subdural hematoma, contusion, diffuse axonal injury, you have various proportions of these different types of damage. On a longer term scale, a number of deficits can persist in people after a TBI, and chronic traumatic encephalopathy is a clinical entity that will manifest likely more extreme versions of all of these things. Here I'm going to focus on monophasic TBI. And so what do we see in patients long term? So we see sleep cycle disturbance quite frequently, 30 to 60% of people. We see epilepsy. Traumatic brain injury is actually the leading cause of epilepsy, ages 15 to 24, can worsen outcomes at the 12-month point. It accounts for 4% of all focal epilepsy. People can experience cognitive impairment at a 1-year follow-up, potentially even longer, post-traumatic stress disorder, which may actually have a genetic basis. Suicidal ideation can be quite common. Persistent headaches, sort of a migraine type form of headache can persist. Dizziness can persist for all the patients who have, sort of these bifrontal contusions. They can become disinhibited, experience personality change, experience impulse and behavioral control problems. And then polypharmacy, which I'll talk about later, can become a very significant issue in these patients long term. And a lot of patients will have economic, social, logistical barriers to long-term follow-up, and don't always have a safe place to wean off medications that they may have needed while hospitalized. So epidemiologically, these are some data from the consortium of TBI model centers, and these give us kind of an idea of, first of all, of who is affected by TBI. Predominantly, these are single white men who are in motor vehicle accidents, typically in their 40s. And what happens to them? We have data now up to 5 years out from injury. And you can tell, kind of initially, many people have to move back in with their families. Many people struggle to remain employed. This is even at 5-year follow-up. You see quite a lot of people have not been able to return to work. Many are unemployed, many retire. This is a measure of functional motor impairment and cognitive impairment. So, this is something that really affects people's lives, life-changing event. And even up to 5 years out, people experience, residual deficits and high degrees of disability. So overall, there are about 3 to 5 million people living with a long-term sequelae of traumatic brain injury. TBI accounts for 1/3 of all injury-related death. And so, at 12-month follow-up, 53% of people with mild TBI continue to have functional impairment. Here is some data from a study published recently in JAMA, showing some assistance measures that are provided by patients' employers. And so modified schedules, reduction of hours, changing of tasks, mentoring, and even among these, you see quite a lot of people who are not able to see a healthcare provider, which we'll address shortly. Within a 2-week time frame, about less than half of people are able to return back to work. But importantly, as we saw on the last slide, even over a year after, many people struggle to return back to work with consequences on their income. And overall, economically, TBI accounts for the $76 billion of costs just from lost wages and hospital care. So, very serious and devastating economic impact. Rehospitalization after TBI. So this is kind of somewhat intentional and certainly feared complication. In the beginning, about 50% of readmissions are elective. So patients need orthopedic surgery, reconstructive surgery, cranioplasty. Over time, fewer of these are elective, and the initial 30 days are where quite a lot of readmissions occur. Why do people get readmitted? So seizures, neurological disorders, hardware infections, brain infections. So as this proportion of elective readmission decreases, you still see quite a lot of people having to return to the hospital. What risk factors can predict who comes back? Older patients with epilepsy, people with pre-existing brain injuries, and as expected, people who have more severe motor and cognitive impairments. So we discussed some of these long-term symptoms that people will experience. PTSD is quite an interesting one, and may have some differences in age and gender. And so this was a study from about 4 years ago, and it actually found that women ages 30 to 39 with mild TBI are actually at higher risk for PTSD. And so here we are looking at questionnaires for PTSD, post-concussion syndrome, the Glasgow Outcome Scale, and an inventory including somatization, depression, anxiety, and some other symptoms. And so these lines here indicate the screening criteria, and here the blue line is indicating a favorable outcome. And so, quite interestingly, we see this difference not just in age, but also in gender. So some of this may occur due to differences in temporal lobe cortical thickness. Progesterone can promote temporal lobe cortical thickness, which may account for some of this difference. There are differences in gray matter volume. The age difference may be related to cortical maturity, and so patients who experience traumatic brain injury before age 25 are actually experiencing this injury before the cortex has fully matured. And then, some social modifiers, differences in reporting may account for some of the other differences. Now, in terms of functional recovery, so Dr. Graffagnino mentioned the study from JAMA in 2021. So I think this is one of the first things I want to show you that cautions us to avoid self-fulfilling prophecies. So if you compare how people are doing after moderate to severe TBI, 12 months out, some people are, actually asymptomatic and completely unimpaired in a disability rating scale, which is incredible. So these are follow-ups of the Glasgow Outcome Scale here and a disability rating scale. And so you can see, quite a lot of people are actually doing well from a standpoint of functional independence. So, again, exercise caution in prognosticating with families. Similarly, I'll show you a couple other studies of recovery of consciousness. And so in general, factors associated with functional independence are younger male patients, lower velocity TBI, absence of intraventricular hemorrhage, absence of subcortical white matter injury, absence of intracranial mass effect, which are certainly intuitive. But I think the key takeaway from this is really, if you look at how patients do, even by the time that they get to rehab, patients who weren't initially following commands when they initially arrive in the ED, by the time that they get to rehab, nearly 90% of them are actually following commands again. This is with a median of 37 days in rehab for people with disorders of consciousness from TBI versus 19 days in those who did not. And so, sure, they spend longer in rehab, but by the time that they leave rehab, again, the majority of these patients have regained the ability to follow commands again. Here are some historical data going back to 1988. If you compare 1988 to 1998 versus 2010 to 2019, you can see, many more of these patients are surviving. And then finally, here's another interesting study. This was a group from MGH that tried to map out where microbleeds happen after TBI. And what they found was there is actually a very high degree of variance in where microbleeds occur, but also the brainstem nuclei responsible for arousal are only partially lesioned. And so, again, patients may look much worse initially than they end up showing you in the long term. So the actual mechanisms of arousal are actually relatively spared and are quite heterogeneous in the actual degree of damage that they experience from the TBI. In terms of prognostication, we discussed diffuse axonal injury. We discussed some characteristics of age and premorbid health status. Certainly differences in the mechanism of injury, penetrating versus blunt, other events that may occur to patients in a hospital, hypotension, hypoxia, seizures, all of these things can adversely affect outcome. But it's a very multifactorial process. Impairments of consciousness are not, as persistently severe as one might expect. Other factors we haven't discussed yet are biomarkers. And so some biomarkers have emerged that predict who might do better or worse. So a lot of these studies have come out of the TRACK TBI group. So plasma GFAP, UCHL1, these can predict an unfavorable outcome at 6 months. Serum amyloid A, IL-15 also predict adverse outcome, high sensitivity CRP. And then finally, an emerging tool in this is point of care testing. Some models have been developed to prognosticate. So these are based on databases of large clinical trials, CRASH and IMPACT. If you look at the website of the London School of Hygiene and Tropical Medicine, they have a prognostic predictor based on characteristics of patients from the database of the CRASH trial. Patients in higher income countries tend to do better, but age, motor score, pupillary reactivity, these are all key prognostic indicators. And then finally, these models have been improved over time, in which the addition of imaging characteristics can help improve the quality of the model. So petechial hemorrhage, midline shift, any of these adverse effects of TBI seen on imaging can also help create an accurate prognostic score. But again, I would caution you to follow the patient's clinical exam rather than these predictors. I'll talk a little bit about medications. So amantadine's received some attention. So in 2012, there was a landmark study in New England Journal of Medicine showing accelerated functional recovery in patients who had received amantadine 4 to 16 weeks after TBI. Here you can see the disability rating scale is improved in patients who had received amantadine compared to placebo. Here are different measures in a cognitive battery of how people did. And so you can see advantages of amantadine. This has been studied in the interim 11 years. And so a systematic review in 2020 found that it's well tolerated, may hold promise. Although the clinical trial data were somewhat heterogeneous and limited by bias, it is well tolerated and may help people. Subsequently, a meta-analysis in 2022 found some moderate evidence for cognitive improvement. So it's unlikely to hurt people. Some of the affected areas after TBI can include abnormal dopaminergic signaling. And so amantadine may have some NMDA receptor inhibition that might promote dopaminergic activity. Finally, polypharmacy. Polypharmacy is a very crucial thing to avoid in these patients. So it's very rare to get out of the hospital after a TBI without any medications. So here we see, 80 to 90% of patients are at least on one medication. Frequently, patients are on psychotropic medications, anti-seizure medications, antidepressants. There was a very, very large study done in Sweden, looking at 240,000 patients. And even a year out, almost half of the patients were still taking medication. And of note, they actually found that over time, the number of medications people take increases, mostly coming from chronic pain. Here is some data from that same paper from Sweden. So again, opioids, anti-seizure medications, antidepressants, these are all quite common. Here you can see how long patients remain on these medications. So certainly, you want to keep a lot of these on for less than 6 months, which tends to happen. But then some of these patients are taking these medications over a year out, and it's questionable the degree to which they really need to be on them or haven't been able to see a doctor to wean them off. In the last couple minutes here, I know I'm short of time, so I'll talk about follow-up care. So follow-up care is a really major barrier to patients, and particularly in uninsured patients and people who have lost income, they're much less likely to have medical follow-up after TBI. In the medical ICU population, there has been a movement toward post-intensive care syndrome clinics. And so Vanderbilt has been a pioneer in this. SCCM has an initiative called Thrive, which is also promoting attention toward long-term care. These clinics basically entail a physician, a pharmacist, a nurse, a psychologist, case manager, PT, OT. And really the key benefit of these clinics is medication reconciliation, coordination of referrals, caregiver resources. There may be some improvements in physician morale to see that your patients have actually been able to come back and are awake and are more functional. And then finally, enrollment in research databases, which I'll touch on here at the very, very end. So there is a network of 16 centers of excellence for moderate to severe TBI that started in 1987. There are certain components that are inherent to all of these clinics, access to a level 1 trauma center, rehab hospital, physician follow-up, neuropsychology follow-up. A lot of the data that we have longitudinally comes from these centers who are able to actually follow patients in some cases 15 years after a TBI. So they have 15,000 patients enrolled in their database, which is incredible. And then finally, Track TBI. Track TBI is a UCSF-based network of 18 sites in which patients are enrolled in a database with imaging, biobanking, research database integration. They have published over 100 papers in the past 10 years and now have core groups focusing on various different research dimensions of TBI. So in conclusion, deficits after TBI can be persistent and multifactorial. Consciousness can improve over time. So avoid self-fulfilling prophecy. Multi-institutional networks are very important from a patient care perspective and for research and epidemiology. And then finally, follow-up care remains a major unmet need for many patients. So thank you.
Thank you both, and also to the case presentation, quite the ICU day. We have nobody banging down the door, so if there are some questions, anyone here? Fire away. So the question is about hypopituitarism.
Well, I don't know, can you comment on it?
Yeah, so I'm one of the psychers and have to help with the behavioral concerns and afterwards. And it was recently discussed in one of our sessions that upwards of 20 to 30 patients who die will develop some degree of dysfunction. Most typically with growth hormone deficiency, but also with some other ones. And there's some literature in some of the larger centers that treat some deficiencies. I know it's not here, but just repeat the question.
Oh, so
Can you repeat the question, please, so the virtual viewers can hear?
So hypopituitarism after traumatic brain injury can be a persistent issue. Yeah.
Oh, there you go. So the question we get all the time in dementia clinic, and there is a dementia ICU overlap, is someone who's had a head injury, not a hockey player, but one, maybe two, military or motorcycle accident, the risk of 20 years later developing dementia or Alzheimer's disease. I know my answer, but I'd like to hear yours.
Yeah, certainly. I think that in a monophasic TBI versus someone who's had recurrent, chronic injuries, the risk is lower, but definitely, is possible. We look at the studies that was showing you of recovery and consciousness, but it's important to also realize those are defined by ability to follow commands. And so there's a pretty large gap between that and full cognitive function. Yeah. So do people with a good functional recovery have increased risk for dementia long-term? I think that they do.
I think that they don't. I mean, it's just not been, it's been studied somewhat in the military especially, but not really well, because everyone as they get old gets Alzheimer's. So how do you know that it's increased in this particular group? The reason that CTE is now recognized is because its pathology is so unique. There's nothing unique about someone with a brain injury who gets Alzheimer's. Go ahead, Mark.
So my comment is, for what you just said, and Alan Rose has always told us that everybody's getting Alzheimer's, is just some of us will die before we get it. If you take away some brain reserve by a head injury or any other process, it would not be a surprise to me that during your lifetime, you'd be more likely to be diagnosed with dementia.
I mean, get symptoms,
Get symptomatic and be diagnosed.
possibly, yeah.
Even if there's not a pathophysiological attribution.
And we see a lot of people in dementia clinic who, are percolating along, then they get some kind of head injury and then it's down the drain. That's common. All right, the rest is just platitudes. Any more questions?
We know if we have certain like genotypes, your outcome may be worse. And there could be a parallel there.
Yeah, do you want to comment on that? ApoE
Yeah,
and
ApoE4,
outcome with head injury?
Yeah, certainly the ApoE4, some people have a genetic predisposition to be more susceptible to cognitive impairment after this.
No, but I mean, does ApoE4 affect
It does.
extent of injury or recovery?
It's associated with worse recovery. Yeah.
All right, thank you very much.
Yeah.